I have a special interest in kids with tuberous sclerosis, which is a disorder that can have similarities to Lennox-Gastaut, and the epilepsy can be very similar, or even be Lennox-Gastaut syndrome, which is part of why I think Tracy gave me the opportunity to talk to you today about other kind of brain causes of LGS. But first, I'd like to wish all the mothers in here a happy Mother's Day. And I wouldn't be here if it weren't for my mom. She was a special ed teacher, actually, for close to 20 years. And she was really instrumental in me getting interested in working with kids with neurologic disability. So I have nothing to disclose. And I have some objectives today that we'll talk about. So Tracy also asked me to kind of define some commonly used medical terms that may seem a little bit confusing. It may be second nature to all of you. And then to talk a little bit about the relationship of infantile spasms and LGS. And probably you've heard some of this already this weekend. And then the meat of our talk today will be to review the different structural or acquired causes of LGS.
I'm sorry, Dr. Randle. Did you
Yes, ma'am.
introduce yourself?
I did, but that's okay.
Awesome. That's Dr. Randle. He is my new friend, and he's going to be amazing. And I'm so sorry I didn't introduce
Oh, that's okay. We just got going. And then I was going to give the disclaimer that if you're interested in genetic causes of LGS, Dr. Mefford will be talking about that right now. So feel free to go there or come back and forth. I won't be offended by any means. Okay, so a couple of terms that we use, and they say when you go to medical school, you learn enough new words that it constitutes a whole language. And so you might have noticed that the doctors you see throw around terms that seem second nature to us, but are completely foreign. So a couple of words that might make a little bit more sense with this talk, congenital, so something that starts in the utero process in a fetus, or kind of as the baby is being born, so something acquired in the early prenatal life. Acquired, we typically use as a term that means that the baby or the person got the disease or the problem after they were born, so not something that was congenital. And then hereditary is another fancy term for genetic or inherited. And sometimes these terms are not quite so black and white and can get a little bit fuzzy. And then the term disease is really a broad term that we use for lots of different conditions that can impair normal functioning. But then when we use the term, and then sign is an objective evidence of disease. So I can see that you have a seizure in front of me, whereas a symptom, someone says, oh, I have a headache or I have pain in a joint. It's hard to kind of see that outwardly. And then when we use the term syndrome really is just a group of signs and symptoms that can occur together and characterize a specific type of disease. So some well-known syndromes, Down syndrome, probably the most common syndrome that people know about, Gervais syndrome, which people have talked a lot about in this conference, and fetal alcohol syndrome. So a quick slide to kind of bring home the differences between syndromes. Down syndrome can be caused is usually genetic. It's usually because you have 3 copies of a certain chromosome, but can be caused for different reasons. And kids often will have a very characteristic appearance. They can have different features to their face, to their tongue, to their tone, or their strength. And then they can have other organs that can be involved. And actually, there's a good number of children with Down syndrome who actually have infantile spasms and can go on to have LGS. Gervais syndrome, a little bit different, also a genetic cause of epilepsy and a genetic syndrome, but doesn't tend, from one kid to the next with Gervais syndrome, they may not have those similar features like you might see in Down syndrome. But the common signs and symptoms in Gervais syndrome is epilepsy, difficulty learning, and changes in behavior. And then the last kind of overview of syndrome is fetal alcohol syndrome, and that's not genetically inherited or acquired, but something related to alcohol use in pregnancy. And kids with fetal alcohol syndrome could have a very similar facial characteristic, some small head size, some other whole body issues. So moving on to LGS, you've all seen a slide similar to this already this week, but it can be caused secondary to a genetic cause, a structural brain change cause, or an acquired cause, or unknown, idiopathic. And we think that about up to 75% of people will have either genetic or structural cause, and of that, about 60% of people have a structural cause. And so it makes up a really large portion of kids with LGS. And then unfortunately, the unknown or idiopathic causes can be very frustrating and often are thought to be probably secondary to a genetic cause. We just don't have that gene right now that we know of. And so I won't go into too much detail on how LGS is defined, because I know that's been talked about throughout this conference. So we'll keep moving on. And so just 2 slides on infantile spasms, which some of you have probably experienced. What we use a term called an epileptic encephalopathy. So infantile spasms is just a type of an epileptic encephalopathy that we see in babies, usually in the first year of life. And the seizures tend to look very similar from one baby to the next, although they may look a little bit different. Each person's different. But often the seizures can have a flexion at the trunk and extension of the arms. They can be repetitive. They can happen more often as you're waking up or falling asleep. And they typically have, babies with infantile spasms typically have a very characteristic EEG abnormality or hypsarrhythmia. And so if you were at Dr. Porter's talk on the first day, she showed you what a normal EEG would look like. And you can see here that this is kind of like a big old mess. And oftentimes we'll say with hypsarrhythmia, if you turn the EEG upside down or on its side, it might look the same as when you look at it straight on. So the reason why you might hear people ask if your child ever had infantile spasms, or why we bring up infantile spasms when you're at a conference for LGS, is that about 30% to half of kids who have had spasms will go on to have LGS. And of kids with LGS, about 40% may have had spasms. So there's a very strong relationship between the two. And I think of LGS as another epileptic encephalopathy, just typically affecting kids a little bit older than spasms. And they may kind of transition from one to the other. Okay, so moving on to the kind of meat of our talk today, we're going to talk about different structural causes of Lennox-Gastaut syndrome. And so there are 6 different categories that I'll touch upon, and happy to take questions at any time during the talk, so just shout out. But first we'll start with infection. And so infection can can cause seizures in a lot of different ways. So either you can have an infection as a fetus or perinatally before the baby is born. And those infections often are referred to as torch infections. And torch is just an acronym for toxoplasmosis. Other right now, the most kind of interesting and exciting field that people are looking into is the Zika virus, rubella, cytomegalovirus, and herpes simplex virus. And I won't go into each virus specifically, but kind of suffice it to say that kids with torch infections may often look fairly similar in terms of the complications that they may have. So they may have a small head size, they may have abnormalities in their brain structure, so either calcifications in the brain or abnormalities in how the brain is shaped or formed. And then most kids have problems with learning or development. Most people have seizures, and majority have hearing or vision problems or both. And so of patients with torch infections, up to 23% can have spasms. That's a pretty high number. And then of people with Lennox-Gastaut, 10% will have had a perinatal or a torch infection. Yes, ma'am?
Do they find that, so if you have the torch infection, is that found during pregnancy, or can they do tests?
Yeah, good question. So you can do testing during pregnancy. So sometimes they'll do like an amniocentesis to look for an active virus. Sometimes they'll check the mother to see if you can tell if a virus is kind of active at that moment or if it's been active in the last few weeks, or you can tell if it's probably just from a long time ago. So they might do that on a blood test. And then certainly after the baby's been born, they can look at the placenta too and check the baby for infection or signs that they've had it. Great question. So I have a picture here of this, actually a head CT, and I should put the caveat that I love neuroradiology and looking at images, so we have a lot of images today. And I'm sure you guys have seen some MRI scans of your kids too. So stop me if you have any questions, but just to make everything confusing, the left side of the picture is the right side of the brain, and then the right side of the picture is the left side of the brain. So I have a circle here over the left part of over the right part of the brain, and you can see these white dots in the middle of the brain. It looks kind of like the bone. And so those are calcifications, can be seen pretty nicely on a head CT, not as well on an MRI. And then this is a kid that we've been following at Children's who, when I see this picture, this is a newborn MRI scan, but what jumps out at me is that these black fluid-filled spaces are too big. And as we move up, you can see that the ventricles are still too big and that there's some funny areas of cyst and probably calcification along the ventricles. And so that would be a very characteristic finding for a baby who is exposed to CMV in utero, or even other torch infections, but CMV being one of the more common ones. Cytomegalovirus, thank you. The C in torch. So moving kind of on to an older age group, so now we're moving out of that prenatal phase to the peri and postnatal phase, and perinatal just really refers to that time around the birth, and then postnatal is usually, we say, a month after you've been born and on. And so both perinatal and postnatally, babies are at risk for a meningitis or an encephalitis. And meningitis just refers to an infection of the covering of the brain. Encephalitis refers to an infection within the brain. And fungal meningitis is actually fairly uncommon in someone who's not on a lot of immune suppressant medicines or with an underlying immunodeficiency. But bacterial meningitis can be acquired in babies and can be very life-threatening to babies. And the type of bacterial meningitis you can get kind of depends on how old you are when you get it, if you get it. And so group B strep and E. coli are two that are more common in the perinatal period, so when the baby's being born around that time. And then Haemophilus influenza, fortunately we have a vaccine for that, so that we have not seen that as much, something that was seen more often in like the early school age kids. And then Neisseria meningitis is something that we often see in older kids. So complications of, yes ma'am.
My son was diagnosed with meningitis at 2.
Mhm.
He started having seizures
Yeah.
up to the age 4. But then we're just now finding out that part of his frontal lobe didn't, I guess, develop
Correctly.
So is it more the infection effect as well as the structural?
Yeah, so you can certainly have an infection affect the way the brain looks. But depending on how the brain looks, the radiologist can usually say if the brain abnormality was like developmental, so something they think that happened when his brain was developing, or something that was related to the infection. So it's hard to know exactly, but certainly it could be 2 different causes. But in medicine, we like to think that something is usually related, right? So you had this one problem, maybe that caused the other problem, like the change in the brain. Oh, he may have been born that way. So yeah, so he could have certainly had an abnormality in how his brain developed and then had an infection. Give you a second risk for seizures, yeah. Yeah, of course. So when a baby or a child has a meningitis, they can look very sick, usually, especially if it's a bacterial meningitis. You can have an infection in the brain, so the meningitis is the covering of the brain that can turn into an encephalitis or in the brain. Sometimes an infection can cause your blood vessels to clot too much, and that can lead to a stroke in the brain. Sometimes the infection can go into the brain and then just sit in one area and form like an abscess, and that can be very seizure-provoking. And then sometimes the infection starts on the covering of the brain, but then can work its way into the ventricle or the middle of the brain and cause an infection in that area, which sometimes can lead to hydrocephalus or enlarging of the ventricles. So for lots of reasons, we get very worried when we see a baby or a child who has a meningitis, because it can be very, very serious and even very life-threatening. So some secondary complications I've listed here. Some kids present with seizures right away, but oftentimes kids will have seizures, well after the infection or even lifelong. And so here's a kid that we've treated recently, and you can see on this MRI scan, the brain is here in the middle, obviously, with the ventricles in the very middle, and then the covering of the brain has this really bright white area, and that's abnormal. So that means that the radiologist gave contrast to the person in the MRI scanner, and then the meninges, or the covering of the brain, was glowing. And so that's a sign of meningitis. And then on the right side of the screen, I have a picture of an abscess. So where the infection goes into the brain and forms a little pocket that has pus in it, and sometimes you'll even need to surgically remove that area because antibiotics may not work. And so the last infection that I'll touch on today is herpes simplex virus, because that is another one that we see fairly commonly, especially in the perinatal period when the baby's around the time that they're born, or even in the first few months of life. When a baby's first born, there may be signs of HSV or herpes simplex virus, only involving the skin, eyes, and mouth area, so not really causing other problems. But more often than that, it'll involve the brain. And a lot of times these babies look very sick. They can have very frequent seizures, become very irritable, and can even affect other organ systems. So these kids are at a high risk for complications.
Can they have this and not have all that visible stuff on?
Yes. You mean the skin? Yeah.
Same with the bacterial meningitis. Can they find that actually have a syphilis?
I guess I've never seen a baby or a person have a bacterial meningitis and look fine. Sometimes you can have a viral meningitis and look okay. You have headache and feel kind of like you have a cold. And then if we, for whatever reason, if we do like a spinal tap, we can see, oh yeah, you actually have a viral meningitis. But no, bacterial meningitis, usually people will die if they don't get treatment for it, so they get very sick. And HSV is similar in that sense, that babies and people tend to look very sick with that. So HSV is a little bit different than the other viruses and bacteria that can cause infection, in that it really has this predisposition to the temporal lobes. And as you may have heard or know, we always worry that temporal lobes are the most epileptogenic or highest risk of seizure-causing area in the brain. And so these kids often do have very frequent seizures. And so you can see on the MRI scan over here, the right side of the brain, it's more white. Kind of hard to see with these lights, but it's a little bit more white and a little bit more swollen than the other side of the brain. And then on this image is another head CT, and we can tell that because the bone is white on the head CT, and you can see in the temporal lobe on the left side of the brain there's white, which means that it's blood. And so it's very common for HSV to cause bleeding in the temporal lobes, which, as you can imagine, would be very dangerous. So just a kind of quick slide on how we treat meningitis and encephalitis is with an appropriately chosen antibacterial, antifungal, or antiviral that targets whatever disease or whatever organism is causing the infection. Okay, so our next group is stroke. And so I've always had people who don't know much about neurology and much about working with kids seem very surprised that kids have strokes, because you think of like an older person who has this stroke that can be very devastating. But in fact, children, it's not uncommon to see a baby who had stroke either in the womb or around the time of delivery, and so we call that a perinatal stroke. And that term is actually a really broad term, referring to a stroke that you could have had around 20 weeks of gestation up to a month of postnatal life. And so that's a pretty large time span. And strokes can be related either to a clot in an artery, so a major blood vessel going to the brain, a vein, which is a blood vessel that drains from the brain, or a bleed. So either the brain's not getting enough oxygen because you have a clot, or there's bleeding in the brain. And so people would ask, like, why are these healthy babies having strokes? And it's kind of interesting that the whole pregnancy process for the mom, it's a very, we call hypercoagulable state, meaning the blood really wants to clot during those times. And so that puts the mother and the baby at risk, actually. When a baby is being born, the placenta needs to clot a little bit to safely transition the baby from relying on the placenta to being able to survive without the placenta. And so sometimes clots from that can come into the baby and cause a stroke. Or it can be a combination of a few different things. And then certainly an infection, like the torch infections we talked about, can increase the risk of stroke as well. So here's a kid that you can see on this MRI scan. So again, on the right side of the brain where we have the arrow pointing, you can see that the brain, for the most part, is kind of like a gray color with a couple of different shades of gray. But on the right side, you can see there's a bright white area. So that would be a sign that this baby had a stroke in that temporal lobe area on the right. And then this is a kid I follow who is a teenager now, and it's a more recent MRI, so not one that would show us the stroke, but it shows us that that ventricle on the left is so big because he had had a stroke probably in that area a long time ago. And so the stroke can cause injury to the tissue that kind of dies from there, and that gets just replaced by fluid. So sometimes kids who have a picture like this may end up needing like a shunt if they have too much fluid in the brain, or may need epilepsy surgery because the area around this may be really active in causing seizures. So when a baby has a stroke, either in the perinatal or the postnatal period, sometimes it can be very hard to tell, and that can be very surprising when we see kids in our clinic who are like 4 to 5 months of age, and they're coming in with new, spells concerning for seizure or infantile spasms, and we do an MRI scan, and this baby has this big area that looked like they had had a stroke before. And that can be pretty common because sometimes kids can have a stroke in the womb and be born and look really good. And I think that's a testament to the fact that the brainstem is really what a baby needs to survive. The brainstem helps them breathe, it helps them feed, and it helps them sleep. So babies don't need to do a whole lot more than that. And then as they get a little bit older, they rely on the outer part of the brain to move and to do other things. Sometimes babies can show signs that they've had a stroke at birth, and so often that's a seizure. So whenever we get asked to see a neonate who had a seizure, that's one of the first things we worry about is did they have a stroke? Sometimes they can have some weakness, so you may see that initially. You may see that they're really floppy or have low tone on that one side initially, and then as they get a little older, they may have a little bit of increased tone on that side. And then I mentioned the seizure already. But up to 8% of kids who have had perinatal strokes can go on to have spasms. So you can imagine that LGS may be in those kids' future. So how do we treat babies who have had strokes? Usually we just say supportive care. There's not a lot that we can do to go in and fix it, unfortunately. If there's a lot of swelling because of that, a surgeon can come in and relieve some of that swelling by maybe like removing part of the bone. Or if there's bleeding, they may need to evacuate some of the blood. And then if you can identify a cause, then maybe you can treat it differently. So if a baby has like a clot in their heart that caused the stroke, then you would treat that a little bit differently. Okay, yes?
Heal itself in some cases with a stroke. I've heard people lose, older people that lose function.
Mm-hmm.
They can't walk and they
Yeah.
part of the brain that's figuring that part out.
Yeah, so that's like probably the best part about working with kids and working with babies is that the brain doesn't heal itself, unfortunately. As you can see with this guy, that area is gone, but a lot of the nearby areas have taken over the function of the area that got injured. And so kids can make a lot more recovery than I would say than in adults. Yes?
How often does perinatal stroke happen? Is it something that during the pregnancy can screen high-risk women or things like that and do something?
There are some women who have a higher risk, and so one question we always ask in a kid that we see for a perinatal stroke is if the mother has had recurrent miscarriages, because that can be a sign that they have a clotting disorder, or certain autoimmune disorders can put you at an increased risk of clotting. So rheumatoid arthritis is one example. And then we also will check a mom for different clotting problems. So there's not much that you can do if you've identified it in the baby, but then we can look in the mom and say, you have this kind of rare clotting disorder, and I help identify that way. And then that can be nice for the mother to know, because then she may not want to be on a medicine that has like a lot of estrogen or a birth control pill, because then that can increase the risk even more.
If the child has a clotting disorder, is there, I know there's association between clotting disorder and stroke,
Mm-hmm.
but is there any type of proven association between clotting disorder and seizures?
I don't think there's an association with clotting disorder and seizures without a stroke or some change to the brain. Yeah, there's usually that's like the linking factor, yeah. Great question. Okay. All right. Really great questions. Thank you for asking those. So to move on to our third group, something that may be familiar to some of you in the audience, but hypoxic ischemic encephalopathy, or the other term I think that we're really trying to use is what we call a neonatal encephalopathy with HIE being a specific type of that. But HIE will break down the 3 words. So hypoxic just means that you're not getting enough oxygen in your tissue. And we use that word a lot. You may have heard that if your child had a seizure and they turned blue, they might say, oh, your child was hypoxic. Ischemic is kind of the fancy word we use when we talk about strokes. So there's not enough blood going to the brain for some reason. So in a stroke, there's a clot there. But in HIE, we think that the blood, for whatever complication during the delivery, the blood is just not moving well to the body. So that's what we use the term ischemia. And then encephalopathy is just our fancy term for the baby or the person is not quite right. So either they're a little sleepy or they're acting funny or they're having lots of seizures. And so you may have heard your doctor say, oh, your child seems encephalopathic today or encephalopathy. So the way we diagnose HIE, and we use this term kind of specifically in neonates, and so those are kids who are full term or late preterm. And as the years go on, we might expand how young we'll give this diagnosis to, but right now we usually say a baby who is born at 35 weeks and above. And then the score they get when they're born, or the Apgar score, which you've probably heard that term before. What was your child's Apgar score? Like, how did they look when they were born? Are they breathing? Do they have a good pulse? Are they pink? And if they don't have a constellation of those things, they get a low Apgar score. And we usually assign Apgar scores up to 10 minutes after the baby's been born. So a kid with HIE will have a low Apgar score. And then they'll have other signs of asphyxia or lack of oxygen. So their blood might look too acidotic. They might have other organs that get injured. And so this is how we diagnose it. So if you don't meet criteria for this, you tend not to get that diagnosis of HIE. So some signs of HIE we kind of touched upon, but the baby may not look very vigorous. They may not be crying. They may not be interested in feeding. They may not be breathing well on their own. They may have seizures initially, or they may have seizures a few days into life. They may be kind of floppy or low tone, not moving a whole lot. And then when we check the blood to see how their other organs look, they may have signs of like liver injury or kidney injury. And this actually can constitute a pretty large portion of kids with Lennox-Gastaut syndrome. So of the 60% or so that we know have a structural cause, up to 17 to 20% may have had HIE. So this is a baby that we're taking care of, and this is going to be hard to see, so we'll just go through it quickly. But this is a brain scan where we look for something really dark, and the dark is the problem. And that's a sign that the brain just didn't get enough oxygen. And so as we move up in this baby's brain, we can see that there's lots of areas that are really dark, which would be a sign of severe HIE. Yes, ma'am?
Can kids with HIE go on to have cerebral palsy?
So that's a great question. And yes, that's often a cause of cerebral palsy. A lot of doctors don't like that term anymore, CP, because it doesn't, it's kind of like a term that people use that doesn't really have a good definition, so it gets thrown around a lot. But yes, in the traditional form of CP, HIE is a common cause of that.
Is the HIE, you call, it's interesting because you explained my son.
Okay.
Oh, that's him.
Yeah.
I never got HIE
Diagnosis.
I was like, oh, great, another diagnosis. But what? Awesome. But is this new? Is it, or
The term HIE.
Yeah.
How old is your son?
11. So he has CP.
So he has CP, yeah.
And now HIE.
Yeah.
I was like, oh, that's interesting.
So in the last 5 years, they had done a study looking at babies with this diagnosis. So this kind of term has been thrown around for a long time, but really in the last 5 to 10 years, it's been taken a lot more seriously because they'd done a randomized study starting in San Francisco, but with other partners across the country looking at, is that where you're coming from? Oh, okay. Where they were like the pioneers of the cooling study for babies. And so now what we do, which is my next slide, when a baby is born with HIE, we will cool them in the NICU. So we'll take their body temperature down to 33 to 35, which I don't know if they may not have done that back in 11 years ago. We probably weren't doing it then. It's really only been standard of care for the last 3 to 5 years, I would say.
And is it standard of care everywhere or only at I live in a rural town with no NICU unit?
Yeah, so now, and I it's hard because I work at level 5 tertiary care center, and
We were at level 1.
Yeah, and so now we get kids transferred from all over the 5-state region that we cover because of HIE to cool them in our NICU. So yeah, if some of the smaller hospitals who have NICUs do it there, but so it would be a standard of care now. Yes.
HIE, is it ever associated with autism or autistic?
Mm-hmm. Yeah, definitely. Definitely can lead to autistic-like behaviors and learning issues as kids get older. And that's where CP really is like a term that we kind of tend to reserve for motor problems. So a kid with cerebral palsy, you can have normal intellect, no seizures, no other complications, but have like a dystonia or a weird posturing of the hand or trouble walking. So that's kind of where I think everyone's getting away from that term CP and trying to describe the symptoms the person is having instead. But yeah, certainly can lead to autism. Yes.
For HIE, have you seen anyone who's had some kind of injury or like umbilical cord wrapped around the neck, and then they present later with seizures? I mean, much later, maybe years later.
Oh yeah, definitely. We were talking about that earlier today. So not all, if you don't meet this criteria, you would not be given a diagnosis of HIE. But there are some kids who look like they're close to meeting this criteria, but they just don't, and then and then if you do, like, let's say you get an MRI when let's say they had a seizure when they were 2, most people at that time would then repeat an MRI, and you might say, oh yeah, they had this little area of injury from birth or something that could be related to the seizure, or not, yeah.
So we barely got my son EEG,
Mm-hmm.
because back then the EEGs took up this massive room.
All the paper.
But it had a bunch of computers.
Uh-huh.
And I had to lay him on this table and keep him up all night. So I know that back then they hadn't done an MRI. So that's why they didn't know,
Yeah.
when.
Oh, about the frontal lobe abnormality, yeah.
So that,
And not all centers are able to do MRI and able to do it in kids, so we have to sedate kids, and some centers don't have the ability to do that safely. Yeah, it's very different.
Just one more question. So whenever you say seizures being enough, so how much later have you seen the seizures show up? And I only ask because Sarah, we were in a small hospital, so they didn't look for these things, but I saw some of these signs.
Mhm.
She's always been developmentally delayed, but I didn't see a seizure until she was 18.
Oh wow.
So how likely is it, or do you even know?
I think it's really hard. I mean, most often kids will present with seizures, like we say school-aged kids, right? So like 7 and under is the most common time to have your first seizure. But I've certainly seen young adults and young women particularly who have gone through adolescence and hormonal changes, and that might be when their seizures presented. I'd say that's a little bit less common that I see that, but it's not unheard of by any means, yeah. Yeah, of course. All right. So the cooling protocol has actually been a really great tool that we now have for these children because it allows us to maybe improve their outcome. And so that's something that we do fairly regularly now. Okay, moving on to trauma. This is always a difficult topic to talk about because actually the most common reason that we see LGS or seizures related to a trauma is secondary to an inflicted trauma or non-accidental trauma or child abuse trauma. And so the term that you may all have heard about is shaken baby syndrome, where there's like a huge campaign, in the last few years that says never shake a baby. You may get frustrated and you don't mean to hurt them, but babies, their brains are just so much more water kind of filled and boggy than an older child. And so between that and then how soft the skull is and how big the head is and how weak the neck is, it can really cause a lot of injury to the brain if they get shook. And so you can see bleeding between the brain and the skull, but more commonly, you can see in this kid that I take care of, if this is like kind of normal brain tissue, which I know you can't really see, but you can see how it's a little bit more white back here where I have the arrows pointing. And as we go up, you can see that there's white stuff kind of throughout the brain. So this is a kid who had a shaking injury and swelling in the brain and tearing of the nerves because of that shake. So he went on to have uncontrolled seizures and now Lennox-Gastaut syndrome. But there are other types of traumas that babies can have. You know, everyone's had a kid or knows someone that had a fall. Kids fall. You know, you turn your back and all of a sudden they're on the ground. Sometimes that can be completely fine. Babies are resilient. Sometimes that can lead to bleeding between the brain and the skull. Sometimes that can lead to an injury in the neck and to the blood vessel in the neck that can then cause a stroke. So we call that a dissection. And then other types of trauma that we can see in babies is like a near drowning, a near SIDS experience. I've seen a couple of babies who unfortunately were left on a adult bed and flipped over or were put on their belly and had an asphyxia, and that can lead to global injury of the brain. And so this slide may overrepresent the amount of epilepsy with trauma because it takes all people with trauma and looks at the resultant epilepsy, but a severe injury, a severe head injury, puts you at a very high risk of epilepsy down the road. So up to 80% of those patients can have seizures, and actually overall constitutes a fairly small group of kids with LGS, but certainly something I see a lot in my practice. Okay, 2 more groups and then we'll be all done. So malformations of cortical development comprises actually a pretty big group. Oh, it's all the way down here. Up to 25% of people with Lennox-Gastaut have some sort of malformation of cortical development. And some of these can be genetic. So, you know, this is where the line between stroke and infection and genetics kind of get blurry. And so often with these kids, we'll do some sort of genetic testing. And if that comes back negative, we may say, well, it could be related to some complication during the pregnancy period. With Hemimegalyncephaly and Megaloncephaly, we do think that those are more likely genetically acquired. And this example is a kid I took care of who, on the right side of his brain, so the left side of the screen, you can see that it looks bigger and thicker than the other side. And as we go up, it becomes maybe a little bit more obvious that it's just thicker over here. And unfortunately, he had very hard to control seizures and needed to have that half of his brain actually removed, which cured his epilepsy, but obviously can put you at a big risk moving forward from there. So that's an example of hemimegalyncephaly, or one side of the brain being too big. Megaloncephaly refers to the whole brain being too big, having too many abnormal cells. You can have abnormalities in how the cells move when the brain's developing. So typically a baby or a fetus, when their brain is developing, the cells start in the very middle and then they work their way to the outer part. And so sometimes they don't quite get there and they move there, but then they get there and they're kind of in the wrong area. And so this is an example of a kid with Schizencephaly, or smooth brain. So the brain's supposed to have really nice squiggles throughout it, or sulci, and you can see on this girl, it's just a very smooth picture. So her brain scan looks like that of a younger, like a fetus actually. And that's often genetic. Lysencephaly. Pachygyria refers to you have curves in the brain or the gyri of the brain, and they're just too thick, and the cells with them in them are too thick. And that can be genetic or acquired. And then heterotopia refers to the cells in the very middle of the brain that never moved to the outer part, and those can be very seizure-inducing. Yes?
Can the brain change over time? Can you do an MRI?
You typically would not. If we scanned her, often we'll like repeat scans just because 10 years later you want to do something, right? But a kid like this with Lysencephaly, in 10 years their scan will probably look the same. Yeah. Same thing with like heterotopias. There are little like balls of cells in the ventricle. Those will be there forever. Yeah. Some of you may have heard of focal cortical dysplasias. Probably the most common cause of epilepsy that I see and that epileptologists see. And this can be hard to tell. Yeah, you can't even see it on there, but sometimes you need a really good radiologist to really point it out to us, and that's where the cells got to the right spot. So we have this nice cortex, 6 layers in our brain, and I like to think of it like a parking lot. You want the cars all perfect in a row. And sometimes with a focal cortical dysplasia, the cars get there, but then they're all parked whatever way they want to be parked. Or they get there and the cells are too big, or they're kind of funny looking, and that can be very epileptogenic. And so often the only way we can treat that type of epilepsy is with surgery.
So is cortical dysplasia always because we were told that our son has cortical dysplasia, but it wasn't like just in one spot.
He has multiple spots.
So it's
Yeah,
not
so-
focal, but it's in multiple.
Yeah. So that's something that we can see. The most common reason for that is a disorder called tuberous sclerosis. I don't know if they ever were worried about, I don't know if they were even worried about that for him. But there are other genetic disorders. A new gene that we just heard about recently is called DEP-DC5, and that can give you multiple areas of dysplasia. Yeah, so you can have, you would still call it, it was, yeah. Yeah, it might not, or if they, yeah. But yes, you can have multiple areas of focal cortical dysplasia. So this is a girl I took care of who had a left frontal or right frontal focal cortical dysplasia, and then we did epilepsy surgery, and she actually did pretty well. She did not have LGS, but a common cause that we see for epilepsy that can lead to LGS. And then kind of in the other category of perinatal or prenatal brain abnormalities are two very specific terms, Schizencephaly and Porncephaly. And this picture shows you a kid who has Schizencephaly. And really what that refers to is you have the ventricles in the middle and you have the fluid on the outside, and there's like a cleft that connects the two. And this area can lead to so many seizures for kids, and so sometimes surgery may be needed. Porncephaly can look somewhat similar to Schizencephaly, but that really just refers to a baby who probably had a stroke as a fetus, and instead of having this this cleft, they may have a big area where there's like a hole and like a cyst in that area. So malformations of cortical development, we've touched on, can be genetic, it can be infectious, it can be vascular or stroke, and so a very common cause of Lennox-Gastaut syndrome. Okay, and our last group, so it's a group that we call Neurocutaneous Disorders, and that's just kind of a fancy name that refers to, as the fetus is developing, the cell, or the precursor to the cells to the skin and the brain are connected, and so there's a problem with that area, or we call the ectoderm. And so usually in kids with a neurocutaneous disorder, the first signs are that they have birthmarks and some sort of neurocognitive issue. So that's where I always ask parents if their kids have birthmarks, and we try and look at every kid at least once without their clothes on to look for that. Most neurocutaneous disorders are genetic, whether they're inherited from a parent or they're just like a spontaneous genetic problem. And most are congenital, or they're all congenital, meaning it starts when the baby is a fetus and doesn't happen after they've been born. And most of them involve lots of different organ systems. So there are, 5 or so neurocutaneous disorders we talk about, but 3 that are more commonly associated with seizures and LGS. And really tuberous sclerosis complex is the one that's most often associated with it. And actually a large group of kids with LGS have a neurocutaneous disorder. So, yes, ma'am.
So you can have tuberous sclerosis and LGS?
Yes.
You have Gervais and LGS?
Yes.
I always felt like those were separate.
No, perfect. Thank you for asking that, yeah. So that's kind of, I think, the take-home point of all of this is you can have a stroke as a baby, and because of that stroke is probably why you have LGS. I mean, I wouldn't bet all of my money on that, but I'd bet like 95% of my money is, the reason why your child has Lennox-Gastaut is because they had a stroke as a baby. Or the reason why your child has LGS is because they have tuberous sclerosis complex. Thank you for saying that. So TSC, some of you may have heard, but this is a clinic I run at Children's, so very close to my heart. This is a group of kids who have a genetic disorder, either affecting one of 2 chromosomes, and the chromosome produces, or the gene that the chromosome is on produces a protein, and the protein is really important to tell the body to stop growing. So we want our body to grow, especially as a kid. You want to become taller and bigger and stronger, but you don't want to grow too much. And so like cancer, for example, something is growing too much and your body's not saying stop. So in this disorder, kids can have overgrowth throughout the body, so not just in the brain and not just on the skin. But we're all here to talk about the brain and seizures, and so we'll move to that. So you can see in this kid, he has multiple areas of focal cortical dysplasia, and I've circled a few of them. But you can see there are lots of little white spots, and that would refer to areas of cortical developmental abnormality. And that's very common in TSC. That's actually one of the diagnostic criteria of TSC. He also has other changes to his brain, but this is probably what's causing his LGS and seizures. Most of these kids have problems with learning or autism or on the spectrum or ADHD or some sort of neuropsychiatric issue. But almost all of these kids have seizures, up to 90%. And of that, most of them have had infantile spasms. And of all the kids with spasms, up to 25% have TSC. So there's a very close relationship. And then certainly we know that that can later evolve into Lennox-Gastaut syndrome. So something that can be very difficult to treat for these kids. So my last slide, I think the take-home points is that you can have, so Lennox-Gastaut syndrome is the epilepsy with the changes on the EEG, may or may not include learning disability. And that's a symptom of something else. And so maybe you had a stroke as a kid, maybe you have tuberous sclerosis, maybe you had an infection, and that's why you have this. And some types of brain injury can put you at a higher risk of having Lennox-Gastaut syndrome, whereas some kids we see who have seizures may not evolve into that. And someday we'll know exactly why that relationship is there. It's important to know why your child, or to identify certain causes of Lennox-Gastaut syndrome, like Gervais syndrome, for example. We want to know if your child has Gervais syndrome because you may avoid certain medicines. Or you want to know if your child has TSC because they may have other problems in other organ systems. But if your child doesn't have if you say, oh, it's idiopathic or we don't know why they have LGS, then you may not need to be as worried about other things. So that's why it's important to know. But so thank you all so much for your attention. I'm happy to take any other questions. Well, yes, lots of good ones already. Thank you.